Good afternoon, everyone. Thank you for joining us today. My name is Nikki Forbinger, and I'll be moderating today's briefing. You'll find American Sign Language interpretation by searching for interpreter stubs in the participants window. Director Dave Jepson is unable to join us today, so Public Health Administrator Elke Shaw-Tulloch will provide opening remarks, followed by Deputy State Epidemiologist Dr. Catherine Turner and Bureau of Laboratories Chief Dr. Christopher Ball. Then we'll take questions from media. With that, I'll turn it over to Elke.
Great, thank you very much, Nikki, and welcome everyone. We appreciate you joining us today on our media briefing. I am very pleased to report that our COVID-19 indicators continue to head in the right direction. Our cases continue to decline. We're meeting our goal of being below a testing positivity rate of 5%, and in fact, we're at 3.7% statewide. COVID-19 hospitalizations and ICU stays continue to decline, and the number of available ICU beds has increased across the state. Today, I'd like to reflect back on the last 2 years. As we just passed the 2-year anniversary of our first COVID case in Idaho, I'll never forget it, Friday, March 13th. So it was our Friday the 13th in the year 2020. Initially, we discussed or focused on building testing capacity at our state lab, informing the public about what we knew and didn't know about the virus, and trying to prevent the spread of the virus. And a turning point in the pandemic came about in December of 2020 when the first COVID vaccines arrived. This marked the availability of a highly effective tool that we had at our disposal to counteract the virus. Clinics sprung up, and we worked hard with our advisory committee to ensure that people at the highest risk of severe outcomes of COVID-19 were able to access the vaccines first, and that it was available throughout the entire state. After a relatively calm summer in 2021, most of us were hoping that the worst of the pandemic was behind us. However, as you know, the past 8 months have been marked by COVID-19 variants and have caused 2 very different surges in cases. Currently, we're entering a new phase. Cases and test positivity are now low, but the pandemic is not over. The virus that causes COVID-19 is here to stay for the foreseeable future. This new phase is marked by ample testing capacity, access to high-quality masks, effective treatment, and plenty of COVID-19 vaccine that is available to those aged 5 years and older. Many more Idahoans now have some immunity to the virus, either from having been infected or from being vaccinated and boosted. Additionally, we'll be monitoring the situation very closely to ensure that tests, treatment, and vaccines are effective against any new variants that may arise, and we're ready to pivot to newer approaches if needed. Also in this new phase, we at the department are making some changes. This will be our last regularly scheduled COVID-19 media briefing. Any future COVID-19 media briefings will be scheduled as needed. In addition, the data on our COVID-19 dashboard will change in this new phase. For example, with the at-home tests becoming more readily available, we will put less emphasis on the day-to-day cases or changes in reported case counts, but we will continue to include hospital capacity. However, our commitment to you remains the same, which is to provide you with accurate and timely information so you can make the most thoughtful decisions to reduce your risk of COVID-19 for you and those around you. And with that, I'm going to turn it over to Dr. Turner.
Thank you, Elke. Today, as Elke mentioned, reported case counts are relatively low, and we have effective vaccines widely available and therapies available to prevent severe disease. With all of these reasons to be optimistic, we do expect that we will continue to have intermittent waves of increased COVID-19 spread in our communities, and that's for a couple of reasons. First, vaccines and prior infection do not necessarily result in long-term immunity. And second, we will likely have new variants that emerge over time. So as we enter the 3rd year of the COVID-19 pandemic, we have shifted away from universal case investigation and contact tracing. And with that, our objectives for tracking the disease are also changing. Our surveillance goals and approaches are going to be updated. We will be making changes to the types of data published on our dashboards, as well as the frequency with which those data are updated, and that'll be coming in the next few weeks. Surveillance for COVID-19 will begin to look a little more like the routine surveillance that we do for other viral respiratory diseases that we track, like influenza or respiratory syncytial virus, or RSV. Some things that will not change is that for at least the next 6 months, we will continue to monitor laboratory testing and document individual positive results to monitor trends in cases. This is especially important as those case numbers are being used at the national level to determine COVID community level indicators. We will continue tracking trends by different characteristics such as age and geography or vaccination status. But without universal case investigations, some characteristics will no longer be tracked, such as symptom onset date. We'll be monitoring severe disease, including COVID-19 associated hospitalizations and deaths, as well as multisystem inflammatory syndrome in children, or MIS-C, and trends among Idahoans with severe disease so that we can determine whether specific interventions or response is necessary at the local level. We will also use the data we are receiving from laboratory reports to help detect and respond to outbreaks and clusters, especially those in congregate residential or healthcare settings where we have people at high risk for severe disease, such as nursing homes, correctional facilities, and homeless shelters. Hospital capacity, as Elke mentioned, will continue to be monitored, and that will be done through data that Idaho hospitals are providing regarding bed and resource availability and their COVID patients. And finally, we'll conduct community level monitoring through sources of data that aren't tied to individual case reporting. This includes tracking COVID-like illness by following trends in emergency department visits using our syndromic surveillance system, and continuing to collaborate with our colleagues at the Idaho Bureau of Laboratories to maintain surveillance for emerging variants of the virus, as well as using wastewater testing as a possible early warning system of increasing viral detection, especially when we have periods of lower COVID-19 disease activity. And with that, I'm going to go ahead and turn it over to Dr. Ball.
Dr. Ball, I think you're still muted.
Thanks, Nikki. You'd think after 2 years I'd get the hang of this. So thank you, Dr. Turner. So I'm going to provide you with just a brief update on where we're at with our statewide wastewater testing program. So I'm happy to announce that 2 of our 5 regional laboratories are up and running and accepting samples from the community. All 5 labs are set up, equipped, and staffed, and the laboratories just in this last couple of weeks have successfully completed our first multi-site method validation study, which is really a way that we can ensure that we can generate comparable data from all 5 laboratories. That multi-site validation was very successful, and we're in the process of sort of refining and simplifying our testing method to move forward so that we can make this easier and more efficient. We're working on developing sampling and transportation logistics for samples, and I'm happy to announce that we've identified solutions for 18 of the 30 community sites that have agreed to participate in our statewide program. For the remaining 12 sites, we're currently trying to identify a solution for getting samples collected and transported to a regional facility. We also have been working in earnest with the folks at the Centers for Disease Control and Prevention with their national wastewater surveillance system to try to get all of our data formatted and in the right configuration for upload into their public-facing dashboard. And I'm happy to announce that the data has been successfully reviewed, gone through their quality control measures, and approved. And we're expecting to see those locations populated on their public-facing dashboards soon. So we have data from 6 Idaho locations that have been uploaded to the CDC News website. We anticipate that hopefully with our next update this evening at 8 o'clock, 3 of those locations will be present on the public-facing dashboard. The other 3 systems that we have data for have served populations that are less than 3,000 people. And due to CDC's data suppression methods, those will not be published on the public-facing dashboard. So we do have 6 sites that we anticipate being able to track, and another 18 that we hope will come online in the coming weeks. So we're very excited to see some forward progress in developing this new system. And with that, I'll turn it over to Nikki Forbing-Orr.
Thanks, Dr. Ball. Okay, we'll now go ahead and take questions from media on the call. Please raise your hand in WebEx or type your question into the chat area. When I say your name, unmute yourself and announce your name and media outlet before asking your question, and then remember to clear your hand when you're done. So with that, we're going to start with Hayat Norimine.
Hi, thank you. I'm from the Idaho Statesman. I just had a question about, and I apologize, I missed a little bit of the beginning, but with the CDC calculating its new community levels, and I just wanted to follow up on the last week, whether DHW still thinks that whether they think that they're using the Idaho data accurately, and if you have an update on that.
Great. Thank you, Hayat. I'll start and then I'll turn it over to Dr. Turner. If you look at our coronavirus-idaho.gov style on the home page, you'll see that we have a kind of a temporary map figure there that depicts the fact that we still are aligning ourselves better with the CDC's data. There are, in some of the methodologies that we're using, I think we discussed that last week, that the CDC is using, they're projecting some of the counties in Idaho to be higher than what our data really show. So we're trying to make sure that the public has that information available, at least until we come a little bit closer in alignment. It'll take just a little bit longer for that to occur. So I will turn it over to Dr. Turner to give you a little bit more refinement of that.
Thanks, Elke. I think the only thing I could possibly add to that is that CDC does not use the data that we submit to them through normal channels. They are actually going out and doing what's called web scraping. And when they do that, they don't have the sort of richness of the data that we're sending them every day. And so it's less precise, and they can't really separate out old cases from new cases, and that's why their numbers are different than ours, and why we felt it was important to display the map in a way that reflects the current situation.
Okay, we'll move on to our next question, which is going to come from Jeremy Stiles.
Good afternoon. This is Jeremy Stiles with KTVB Television and KTVB.com. My question has to do with vaccinations. I have some folks starting to ask, when are we supposed to get our next shot? If, say, we had the booster 6 months ago, or third dose, are we going to need to get it soon? What is the guidance on that? And I fully understand that it's probably going to be different for each patient, but what's the general guidance and fourth dose?
Okay. Yeah, thank you, Jeremy. And you're correct that it is a little bit different for each person. And I will see if Dr. Hahn wants to start, and have Sarah Leeds also to give some information.
Sure. Yeah, thank you for that question. That is a really important question. And right now, there is no it's kind of easy because there is no recommendation yet. That said, there is a little bit, it's interesting. Pfizer is signaling and is requesting FDA to approve a second booster, if you will, at least in seniors. And the CEO of Pfizer is talking about how maybe more people are going to need boosters, so another booster. So they're seeming to look at their data and say they think that people are going to need that fourth dose, if you will. Moderna, on the other hand, right now is, again, and this is the CEO is talking, it's not any official, but that maybe only immunocompromised might ultimately need a fourth dose. So I think we might see, it'll be interesting to see if we see a parting of the ways here between those two mRNA vaccines. But for the moment, we need to stay tuned and see what the FDA, and they are convening their special advisory committee. VRBPAC is supposed to be convening sometime in April next month to really talk about this, because everybody realizes we need to, come up with those recommendations as soon as we can. Obviously based first on FDA authorization, but also start thinking ahead to what about this fall, if we're going to expect another wave either in the fall or even before then. And Sarah, I don't know if you had anything to add.
The only thing I would add is that we have plenty of vaccine and are ready for that if it's needed.
Okay, we'll move on to our next question, and that's going to come from Kyle Pfannenstiel.
Thanks, Nikki, and thank you all for your time. So cases are down from the Omicron peak, but daily infection reports are still quite a bit higher than during the lulls last year. I'm wondering two things. How do state officials define a low infection rate for Idaho, and why? Thank you.
Thanks, Kyle. I'm going to start with Dr. Turner and Dr. Hahn following.
Thanks, Elke. So Kyle, it's a great question. Let's just say there's no magic number. One of the things about dealing with a novel virus is that we don't have a history to base what we would, kind of those expected counts that we would get every, for instance, flu season or something like that. And so what I will say, though, is that back in July, the last time we had low case numbers, like almost a whole year ago, we were getting roughly 300 to 400 cases a week. And we are still up in the, 3,000 range. So we've got a long way to go before we even reach the pre-Delta surge levels that we were seeing. But I'll turn it over to Dr. Hahn and see if she wants to add anything there.
Yeah, Kathy, sorry. Yeah, I don't have anything to add to that.
Thank you. And could I ask a quick follow-up? You mentioned how the state will be changing how it reports daily case reports. Could you give a little bit more detail on what that will look like? Will it be reporting on a weekly basis, like the flu, or what might that look like?
Yeah, thanks, Kyle. I'm going to turn that one back to Dr. Turner again.
Yeah, thanks, Kyle. Those are the conversations we're having right now. We're certainly not going to change tomorrow. I mean, things are not going to transition tomorrow. It'll be very slow. We'll turn the heat down slowly. But I think some of the things that you might notice first is that we aren't reporting out some of the details that we have been. For instance, I'm sure you're aware that we put on our dashboard like the number of healthcare workers, we have a curve of onset dates. Well, if we're not doing case investigations, we may not have those data or have them in all cases, and so throwing them up on the dashboard is kind of taking it out of context. So we might make those changes first, and then we'll change the cadence of those updates slowly. We don't want to back off completely because, like I said, we want to move towards optimism, but we will also want to be poised so that if we do see another surge, we don't have to rebuild everything back up to where we were.
Thank you.
Okay, we'll move on to Rachel Cohen.
Hi, this is Rachel with Boise State Public Radio. I just wanted to follow up with Dr. Ball on some of the wastewater testing. I was wondering if you could give some examples of communities that are doing that currently, where we can expect to see some of that data coming from, and maybe some that are currently working on it. And I was wondering if the communities are too small, for example, to be included in the CDC data. Is there a way that that is going to be presented at the state level?
Great questions, Rachel. And Dr. Ball?
Great, thank you, Rachel. So what we're planning to do is contribute all of our data to the news site, the CDC news site, so the National Wastewater Surveillance System. And the way that news presents that data is that they will give the sewer shed or the wastewater treatment facility a random number, and then they will place that on a map in the zip code where that facility is. And so because of the conversations that we've had when we've been onboarding folks and the nature with which CDC is presenting that data, we're not identifying specific communities at the state level. So at this point, you'll get a general idea of where the locations are by looking at the site that is presented on the map. I'm give you a general sense of where they are. What I can tell you is the 30 facilities that we've reached out to, we have representation in each of Idaho's public health districts. Most of the sites that we have consistent data for are in public health districts 1 and 2, and they've been working consistently with the regional laboratory up in the University of Idaho. We also have, as I'm sure you are aware, because City of Boise has made that information public, that we have 2 sites here in the City of Boise that have been contributing wastewater data from the beginning of the pandemic. And currently that sampling is being processed at a laboratory at Boise State University. So as we get the Idaho Bureau of Labs laboratory fully functional, as well as the ones at Idaho State and Lewis and Clark State College, we'll be starting to send samples from around the state to each of those locations. And as those data get processed and posted, you'll get a general sense of what communities they may be just based on where they are on the map. Idaho is such a small state that when you see a dot on a map, it's going to give you a pretty good idea of who's contributing and who isn't. And then for those communities that are serving populations less than 3,000, there's actually 2 different versions of the news dashboard. There's one that is available publicly, and then there's another one that is available for public health professionals. And so as we start to populate additional data points for those smaller systems, we'll be reaching out and working with those facilities to see what their comfort level is with us publishing their data and move forward as we start continuing to develop that program.
Okay, thanks, Dr. Ball. Looks like Hayat has another question.
Hi, thank you. Realizing this is a really sensitive issue, but there are some very public allegations, possibly some misinformation being spread of vaccinations being given to a baby without the family's permission. Is there anything general you can say about this? Can the department confirm that this is not something the state does when a child is under protective services?
It's a good question, Hyde. I'm not familiar with any of the allegations or anything along those lines, and I will see if Dr. Hahn or Sarah have any additional information about that. But there is a need to have parental consent for any vaccine that's provided.
Yeah, Elke, like you, I would just say in general, of course, parental consent is required, but I think I'm certainly not familiar with all the procedures and other parts of the department policies. Sarah may be more familiar because it relates to our vaccine program, but I'm not sure if she will. Sarah, are you able to add
I don't have any additional information. I'm also not aware of the allegations that are mentioned. I will say the state of the immunization program provides vaccine to providers who then, like, we don't vaccinate. We are not direct vaccinators. So, but again, they're required to have parental consent.
Thank you.
Okay, our next question is going to come from Melissa Davlin.
Hi, sorry, I have a crying baby. I'll write it in the chat.
Okay, as we wait for her to type that into the chat, I
think
am
I'm
not.
good now, actually. Sorry, Nikki.
Okay.
So generally speaking, you mentioned it's been 2 years, and I think that last summer, after vaccines became widely available, I remember kind of a similar call where you all talked about being cautiously optimistic about the next several months. What's different about this time around? Are you personally feeling optimistic? And I would put this out to anyone.
That's a good question. I think we covered this, I think, last time as well, that, you know, we don't have any crystal balls. I'm still personally using the phrase cautiously optimistic. I do feel that things are different because, as I was mentioning in my opening remarks, we have these highly effective tools. We've gone through waves of this, and we all have, you know, a much better base of knowledge now as well. We know what it takes to overcome cases spreading as a community. We have lots of opportunities for people to do take those measures that help keep us healthy. And I'm also, you know, we have additional, more Idahoans who have immunity, whether that's a natural immunity or vaccine immunity. So to me, that feels different than where we were last summer, where people were getting vaccinated, but there wasn't that opportunity to really see how bad things could get. So my hope is that we have some collective knowledge and experience now that will help shape this in the future. But I'm going to turn it over to any of my colleagues who want to join in here to make some remarks on it. I feel a little bit better than I did last time, but I'm going to certainly stay at the ready to jump if we need to do something. Dr. Hahn?
Yeah, okay, I think you summarized it well. I think we want to be very careful to say we are hopeful. We are in a better place. We have a lot higher population level immunity, some of that from having been infected, some of that from having been vaccinated and boosted. But we have a lot more population level immunity. Of course, we're watching very closely right now the Omicron BA.2, which I'm sure many of you are aware is now starting to apparently cause upticks in several countries in Europe. So we are watching that carefully. We also have, but we have better population immunity. Of course, for some people that may have worn off, just like we were talking about. Are we going to be needing more boosters or other recommendations? But we also do have some medications out there in the public now, antiviral medications, other therapeutics, the monoclonal antibodies, some of which I should say the BA.2 is known to be susceptible to, if you will. So even though I share Elke's optimism and hope, we also want to be very careful to not overstate our confidence that that's what's going to happen. We do anticipate that the potential for future variants is significant, and that we want to make sure people don't say, but you said it was over, because we're not saying it's over. We're saying that like last year, we see things headed in a good direction. We have more reason to hope even than last year that this could be more durable because of the higher population level immunity and maybe better tools to respond.
Hey, thank you so much for the answer. And also thank you over the last several months for taking so much time to explain all of this to us over so many meetings. We appreciate it.
Thank you.
Okay, we'll move on to another question from Rachel Cohen.
Thank you. Just wanted to ask about the federal government's announcement that they were winding down some COVID-related programs because of lack of funding, like just testing and vaccinating for uninsured people and potentially monoclonal antibodies. Will those decisions affect Idaho and the supplies it has to respond? And then the second part of my question is just looking at the vaccination rates. Currently, are there areas, age ranges, geographical, that the state is focusing on in trying to get that vaccination rate up?
Yeah, thanks, Rachel. I'll address the first question, and I'll send the second half about the vaccination rates over to Sarah Leeds. With regard to the actions that the federal government is taking, I will give we'll wait and see. Certainly there will be some impacts to us. We'll need to really look at each one of those items to see how deeply or not it may affect Idaho. It may be some of those scaling back of activities that they're doing at the federal level may not impact us that greatly because we don't really have the population base, or we can do things in a different way that don't take as many resources. So I will give you, we'll have to do a little bit of wait and see as we unfold that a little bit more. And for the vaccination questions, I'll turn that over to Sarah Leeds.
Yeah, thank you, Elke. Yeah, we're I hate to say kind of focused on everything, but each age group we want to continue to encourage folks to get vaccinated. However, we are lowest in our terms of our coverage of age groups in those younger kids, 5 to 11-year-olds, and then adolescents. And so we really are trying to make some inroads there with both providers and looking to see what kind of barriers that are out there that we can remove, and what kind of education efforts and awareness efforts that we can address. And that's just an ongoing activity that we do. So we will continue to do that. We're also working with our health equity work group and committee to they're working on full-blown health equity, and we focus a little more on vaccine equity, and anywhere in that realm we're looking to improve efforts. I mean, we fully feel like there's always room for improvement, and so we continue to look and make improvement efforts. It feels like we're at a transition point where we can devote a little more time to focusing on quality improvement and where we need to improve our education and outreach at this point, where it's not less urgent, but the vaccine is readily available, and that work has been done, and now we just need to continue to maintain that and look to the areas where we can improve.
Thanks, Sarah. So it looks like Melissa Davlin has her hand up again. If you have another question, Melissa.
Sorry, I forgot to raise my hand.
Oh, okay. I am not seeing any more hands raised. So we'll go ahead and wrap it up. Thank you very much for joining us today. And don't take this personally, but we hope we don't have to see you again for a while. Have a good afternoon.